Hi, everyone. Welcome to the IGHS COVID series. We're delighted to have all of you attend and learn today about some of the fantastic work that's being done to address the challenges associated with the pandemic in the Navajo Nation. My name is Colin Boyle. Let me welcome all of you to the webinar and hand things off to Jaime Sepulveda to introduce our speakers.
Thank you all, and apologies for the technical difficulties we were facing. This is Serving in Solidarity, UCSF and the Navajo Nation, part of the IGHS COVID-19 series. We're very excited to have this fantastic group of panelists. Dr. Shamasunder is co-founder of the HEAL Initiative and associate clinical professor at UCSF. We also have Dr. Sam Percy, who's anesthesiologist and part of the UCSF Health Initiative Fellow, and Dr. Adriann Begay, who is an expert in family medicine and works in the Navajo Nation as a doctor. So we have a great panel on a very important issue, and I will hand this over to Sri. Sri, you have the floor. Thank you.
Awesome. Thank you, Jaime and Colin, for inviting us, and IGHS for hosting this conversation. And I think it's super exciting because we have a lot of the panelists here are people that are doing work in Navajo Nation, Dr. Begay and Dr. Percy, and both of them are HEAL Fellows, and I learned a tremendous amount from them. I just wanted to set up some of the context for what we're doing in Navajo Nation in order to kind of pass it off to Dr. Begay as she speaks more eloquently and with much more experiential wisdom than I can about Navajo Nation. And so just as many of you might know, at UCSF, the HEAL Initiative is a global health fellowship. It's a 2-year immersive program that works in Navajo Nation and 9 other countries around the world. And so we've actually been working since 2015 in Navajo Nation. And the goal of HEAL, like all of us believe in global health is a human right, that all people deserve high quality healthcare, especially the most vulnerable. And so with that principle, we've been focusing on frontline health professionals to serve the underserved for the last 5 years. And so in Navajo Nation for the last 5 years, we had 49 health professionals that are doctors and nurses and others, community health workers that were working in Navajo Nation before COVID started. And then when COVID started to surge in Navajo Nation, a lot of our partners, including Dr. Begay, started to ask the question, we really need nurses. We need critical care nurses. We need ED nurses. How do we support a larger group of nurses coming to Navajo Nation? And that's when we went to UCSF, leadership, Mark Laird and Josh Adler and Sheila Antrim, and had this conversation. And I think to a huge credit of UCSF's, like really leaning into solidarity at this moment where we had flattened the curve in San Francisco, and there was a real interest in how do we lean into health equity more as an institution, as UCSF. And so we came now 3 weeks ago, and I would say 10 days before we arrived in Navajo Nation, we started to have these conversations. And there were 70 nurses that volunteered, and we ended up coming 3 weeks ago tomorrow with 7 doctors, critical care docs, and hospitalists, as well as 14 nurses across 3 sites. And so those 3 sites are Shiprock, Chinle, and Gallup. And so you'll hear more about that from Sam and Dr. Begay. But we are in a surge. I'll let them talk about the clinical side. I think the 2 intro points that I wanted to make was that we've actually been doing a lot of like some media from just people in San Francisco and others that have wanted to know about this work. And I think the 2 you know, just two lenses that I think are important for global health in this moment, and always, but especially in this moment, is that, you know, so many reporters lean in with this question of how come there's a surge in Navajo Nation, and anchor to behavioral causes. You know, the underlying tone of the question is, you know, what is it culturally that has caused the surge to happen in Navajo Nation? So, you know, that is like a subtly racist question that I think it's important for us to reframe in structural ways. So moving from the behavioral context to a structural understanding of why there's a surge, and Dr. Begay will talk more about that. But, you know, you can't talk about diabetes and obesity in Navajo Nation without talking about the fact that there's 13 grocery stores across 27,000 square miles of Navajo Nation, right? And you can't talk about the health system of IHS without stating that there's been, you know, IHS has funded 1/3 the rate per capita as the VA or Medicare, and so people want us to talk about, you know, water, the fact that, you know, a third of Navajo Nation doesn't have running water or electricity. And so we have to talk about infrastructure and the fact that sheltering in place is a, you know, for people of privilege is a possibility, you know, and it's an inconvenience, but for a lot of people on Navajo Nation, it's an impossibility. And so how do we think about these structural lenses in global health when we talk about the work and move away from some of the behavioral lenses? You know, I think similarly, the disparities across, like, COVID is laying bare, whether it's Chicago or Michigan or New Orleans or correctional facilities, people of color in this country, vulnerable populations, are getting hardest hit. And so how do we talk about that? Just like, you know, I think Ahmaud Arbery getting, you know, lynched, essentially murdered over the, you know, in February, and now we're having a national conversation again. You can't talk about the deep south of Georgia without talking about the history of slavery, and you can't talk about Navajo Nation and the surge without talking about genocide. And so I think those are all linked, and that's important for us to make those connections in global health. And then I think lastly, you know, I think this, hopefully this panel models well, is that, you know, we are here in solidarity, and we are running a sprint when most of our Navajo colleagues are running a marathon before COVID, during COVID, after COVID. And so there's resilience and resourcefulness in Navajo Nation. There's amazing leadership, and we are here in solidarity of that. And so we have, you know, I think having Navajo voices speak for themselves obviously is important. And so in global health, how do we lean in with solidarity rather than the savior? So moving from savior, which is also the story that I think subtly or unsubtly the media wants to tell, to a solidarity frame. So I'll stop there. I think in global health, trying to move from behavioral to structural in our analysis, and moving from you know, the savior to solidarity. And so with that, I'll pass it over to one of my mentors, Dr. Begay, one of many of our mentors. She's, you know, senior leadership at Gallup Indian Medical Center. She's a force to be reckoned with, and she's, you know, very inspiring on many levels. So I'm so glad that she will be sharing with us. Thank you.
Okay, good afternoon. And thank you very much for inviting me to speak today regarding my people's fight with coronavirus and the disparities that it's bringing to light. Can you go to the next slide? So before I begin, I'd really like to appropriately introduce myself in the way that I was taught. So she Adriann Begay and she tobahenishne but ani bashichin kan zahni dashiche dot ashti dashanale akut ego de nestanishne. So what I'm telling you is my clans of how I am and how I am a Navajo woman. Next slide, please. First and foremost, I'd like to remind everybody that American Indians and Alaska Natives are unique in that we are born with a legal right to health care. Next slide. The legal basis for these rights stem from multiple treaties in which the United States government entered with individual tribes in exchange for land and natural resources. In addition, there were multiple executive orders from multiple court decisions and numerous other laws. Next slide. But most importantly, the first treaty was done over 200 years ago in 1779. And in that time period, we have survived 200 years of evolving federal policies. The first phase, there's what we call the phases of federal policy for Indian people. The first phase is the annihilation phase, in which was in the 1800s, in which we saw the Indian Removal Act of 1830. And these were just examples of where people were removed from their native lands, like the Cherokees, where they underwent the Trail of Tears. We saw that there were the killing of over 3,000 Seminoles in Florida. And this also saw the creation of reservations through the United States. The next phase is forced assimilation. That was from the 1800s to about 1950s. And this was an effort to transform American Indian culture into European American culture, with goals to pressure Native Americans to become farmers or ranchers or business people. But it was also the development of boarding schools, where children were forcibly taken away from families, taken across the country to, and some never returned. There are stories of young Indian children still being lost and buried there and never came home to their families. But the main thing was assimilating these children so that they were no longer native. The next phase was termination and relocation, and this was around the 1950s. And we saw the termination of a number of tribes, in which tribes were ordered to give up their land, give up their resources. And so once they gave up their land, then they were they were no longer in need of federal aid. And so these tribes were terminated. One of the biggest programs also was a relocation program. And there were relocation sites that forcibly had Native American, young adults, Native American, to go to areas like Los Angeles, San Francisco, Oakland, Detroit, Denver, Dallas, and told to complete vocational school there. Unfortunately, again, that's why there's always the joke that you can go anywhere in the United States and you always run into a Navajo. But that's the reason why we find a lot of Native Americans in these larger cities was because of this relocation program. But the overall goal was to remove American Indians from reservations in order to promote assimilation. The last phase, which started in the 1970s, was self-determination. This authorized American Indians to assume responsibilities for direct operation and administration of programs under the Bureau of Indian Affairs and under Indian Health Service. And this is where we find the development of what we call tribally run clinics, or you'll hear the term 638 clinics. But there's still some distrust from a lot of Native Americans because they feel like this is the government's way of relinquishing their trust responsibility to American Indians for the land that we gave in exchange for the right to have health care, the right to have an education. Next slide, please. So why are all of these policies and laws and treaties so important? Well, out of these policies came the establishment of Indian Health Service in 1955. And the primary responsibility is to provide health care for American Indians and Alaska Natives, with the mission to raise the physical, mental, social, and spiritual health of American Indians, Alaska Natives to the highest level. So the Indian Health Service is comprised of 46 hospitals and 556 health centers, health stations, village clinics, or school health centers. So for fiscal year 2018, there were over 40,000 inpatient admissions and over 13 million outpatient visits. Next slide, please. So Indian Health Service is administered through a system of 12 area offices and over 170 IHS and tribally managed service units. The service population, they serve 2.56 million American Indian Alaska Natives from 573 federally recognized tribes in 37 states. For fiscal year 2018, as I said, there was over 41,000 outpatient admissions. Next slide, please. So as of 2 days ago, the cases reported for the number of positive COVID cases was a total of 5,467. Of that, 3,363 are positive within the Navajo area. So this is 61.5% of all positive cases across Indian Health Service are on the Navajo Reservation. Next slide. So the Navajo Reservation, the landmass is primarily in the state of Arizona with extensions into New Mexico and Utah. It's a little bit larger than the state of West Virginia at 27,000 square miles. And in 2010, the census showed a total enrollment of individuals who claim to be Navajo to be over 332,000, with 47% of those individuals living on the reservation, which comes to about 157,000 that live on the reservation. Again, during the census, the average household income was a little over 27,000. When you compare that to US, I think the US during that year was 44,000 per capita. And the unemployment rate is at 55.9%. So as I mentioned before, as of May 10th, there were over 3,000 cases of COVID on the reservation. So the Navajo Reservation is now second behind the state of New York in the number of positive COVID cases per capita. And this is complicated because when you have, as Sri said, if you have a third of your population that lives on the reservation, does not have running water, how are they supposed to do hand hygiene? They can't buy hand sanitizer because they only have 13 grocery stores that cover this area. And coming into the border towns is difficult because of the transportation issues also. As health professionals, we know that health disparities exist because of disproportionate poverty, discrimination in the delivery of health services, inadequate education, and cultural differences, which are all rooted in economic adversity and poor social conditions. These disparities are even more apparent during this COVID health crisis. So if the federal government is responsible for raising the physical, mental, social, and spiritual health of American Indians and Alaska Natives, what's the problem? Next slide. So according to the 2018 expenditures per capita report, you can see that the actual IHS spending per user was 3,779. If you compare this to the VA's medical spending per patients, this is the VA is almost 3 times the amount of Indian Health Service. For Medicare, it's almost 4 times. They're at $13,000, over $13,000 per beneficiary, and Medicaid is 2.5 times at $8,000. So there's a significant funding disparity which leads to major issues. There's substandard appropriations that leads to outdated facilities. And some of the facilities, Indian Health Service facilities, are the oldest in the country. This hospital where I work at Gallup Indian Medical Center was built in 1960. So you have, and we all know that trying to run an outdated facility is going to cost more than a facility that's about 10 years old. In addition, the inability to appropriately equip sites with updated IT technology and failing infrastructure creates unsafe and unsanitary living conditions and severely compromises the quality of care that can be provided. This is so evident, again, as I mentioned before, when we don't have running water, we don't have electricity, and during the cold seasons, there's many homes that are still run, that are still heated with wood and coal. So despite the fact that the provision of healthcare to American Indians and Alaska Native is a legal trust obligation of the federal government, Indian Health Service is still funded on the discretionary side of the budget, meaning, number one, that the budget does not increase with inflation or population. The budget does not increase with new technologies, and the purchasing power decreases each year because it's subjected to sequestration under the Budget Controlled Act of 2011. Next slide. So here are some mortality disparity reports from 2009 and 2011. And it shows that accidents, unintentional injuries, diabetes, alcohol-induced diseases, chronic liver disease, and cirrhosis, and assaults, including homicide, are 2.1 to 6.6 times higher than US all races. And just like in the years past, there was smallpox, there was tuberculosis, we are once again dealing with an infectious disease that killed many American Indian and Alaska Natives. And we find ourselves here again, once again. Next slide. However, resilience, the ability to recover readily from adversity, is tied into the Navajo teaching of Hojon Asli, which means it will be with beauty again, the teaching of hope. As American Indians and Alaska Natives, we have been doing this for over 200 years. It will be our Keh, which is our teaching of kinship, and our relationships that we build and create that will help us through this pandemic. The relationships are based on respect, caring, protection, and support. Next slide. So my own personal view and the view of individuals that I turn to in this virus, which is called the POS, is part of nature, that this virus is part of nature. And although it has created this crisis in all of our lives, we still must respect it and learn that nature is far stronger than we are. And so we can never assume or think that we are stronger. Many of us are afraid. Many of us have seen a death far too many times during this pandemic. And many of us have been affected in some way. But we still each have desire to care for others, to lift up those who need help to stand right beside you, and to make things better for those who lack support and resources. So to you, I say, thank you. And again, Hojon Asli. Thank you.
Thank you so much, Dr. Begay. That was an excellent presentation, very moving, and I'm sure it will raise a lot of questions. Before we get into the Q&A, I would like to invite Dr. Sam Percy to give his presentation. Sam.
Thank you very much. And thanks, Dr. Begay, for being a mentor for us in the HEAL Fellowship, and now for many folks at UCSF and sharing your wisdom. Just like Dr. Begay began with introducing myself, I'll begin by introducing myself, and I apologize to Dr. Begay for my poor pronunciation. Yatte Sam Percy Initiate Norwegian Nishlit Biket Sin Dene Bashich Chin. So hello everyone, my name's Sam Percy. I was born to the Norwegian people, born for the wooden shoe people of Holland. My maternal grandparents are German, my paternal grandparents are Irish, and I come from the area of the Rock with Wings, or Shiprock, New Mexico. So I was tasked with talking about surgery and critical care on Navajo Nation with a specific focus on these areas during the COVID-19 pandemic. So like Sri mentioned, I am a first-year HEAL fellow, and I've been in Chinle, Arizona, which is essentially in the center of Navajo Nation since August. So have seen sort of how care worked before the pandemic, and now sort of have seen how care works during the pandemic. So I'm gonna, next slide, please. I'm gonna frame my talk sort of foundational in a critical element of sort of the Navajo way of thinking, which is in the 4 directions. So in the traditional Navajo homeland, there are 4 sacred mountains in each of the 4 cardinal directions. And when moving between them, always starting in the east where the sun rises and sort of going in a clockwise direction. So I'll move this way on my presentation, sort of starting in the east with thinking, sort of in our pre-pandemic phase, and then move on to the south where we were planning as we saw the pandemic grow around the world. Currently, we're sort of in the west in the implementing phase and the acting phase, where we have a surge and are trying to heal as best we can with the pandemic, and then talk about potential future directions of how we can reflect and look back upon what happened as we move on to the north. Next slide, please. So first off, looking at the east before the pandemic, Dr. Begay did a great job of describing the Navajo area IHS specifically. Within Navajo area IHS, there are 5 hospitals on Navajo Nation itself that provide surgical and critical care capacity. Those facilities include Gallup, where Dr. Begay works, Fort Defiance, Chinle, where I have been working for the last 9 months, Tuba City, and Northern Navajo Medical Center. Across these groups, looking at sort of critical care capacity, there are around a little over 20 ICU beds, or a little over 30 ventilators, and then depending on the site, varying number of staff and staff with comfort with critical care. I'm going to mainly focus on Chinle because that's where I have the most experience with, but if you have questions about other facilities on IHS, we can address them during the Q&A. Next slide, please. So the Chinle Comprehensive Healthcare Facility is a 60-bed hospital, also built a long time ago, built in the early 1980s, focusing on the critical care and surgical side, has a 4-bed special care unit. This is pre-pandemic, and had 5 respiratory therapists that helped man this unit. It was an open unit. We had no ICU consultants, and very often, at least my experience in this unit, is if a patient had to be mechanically ventilated, they were only able to be kept in the unit for 10 to 12 hours and then flown out because we often didn't have enough nursing staff comfortable managing mechanical ventilators and the sedation required to go along with that. So these patients were often transferred out. On the surgical side, we have 2 operating rooms and then a surgical staff that consists of 2 anesthesiologists, 1 CRNA, 5 general surgeons, 4 OBGYNs, and 2 podiatrists. We do pretty broad spectrum general surgery prior to the pandemic. So a lot of GI cases, significant number of lap choles, lap appies. We do pediatric cases down to 2 years old, and then the sort of broad spectrum OBGYN care as well. Pre-pandemic, I would say it was relatively rare for us to have many patients in the special care unit. We had a moderately busy surgical service, but as the pandemic has evolved, we have really adapted our facility and our critical care capacity to attempt to manage the patients as best we can. Next slide, please. So moving into the South, or the planning phase, as we saw starting in China and then moving across the world, the pandemic growing, and then sort of come domestically into the United States and then start to see a few cases on Navajo Nation, we moved into the planning phase and developed an incident command team, which sought to really make our facility ready for what we thought was going to be a significant surge. And that really started on the facility side. So we thought, okay, our hospital currently only has about 4 beds that can take critical care patients. We were anticipating needing a lot more than that. Like Dr. Begay mentioned, there's a long history of not many people showing up to help with various health crises or many other problems that have afflicted Indigenous people over the last several hundred years. And I think our incident command team was really preparing to go it alone. And we'll talk about that. Luckily, that has not been the case. But we were anticipating having to manage the patients that came in on our own with very little help from the outside. So we converted our pediatric care unit into a 13-bed respiratory care unit with quasi-negative pressure rooms in all of those rooms, and then 2 true negative pressure rooms. We had 6 ventilators, 6 high-flow nasal cannula machines, and then the staff I had described before on the respiratory therapy and anesthesia side. One of the main focuses of our incident command team related to critical care was testing. You can't admit patients to the hospital or treat them for COVID if you don't know they're COVID positive. So we developed a pretty robust respiratory clinic very early on, and we're aggressively testing many of our community members. Unfortunately, our test turnaround time was at best 5 to 10 days, often on the order of 15 days. So although we were testing folks, we were often treating blindly early on because we did not know, despite them having symptoms, whether this was COVID or something else. As an example of this, just recently, and the challenges Dr. Begay mentions, we had a patient who was tested on April 20th now, turned out to be positive with a more rapid test, which we have now, and was not able to get in, we were not able to get in contact with the patient until May 7th, so 17 days later, because every phone number we had for the patient was disconnected and we had no way of getting in contact. So for 17 days, this patient, who was luckily asymptomatic, was moving throughout the community not knowing they were COVID positive for many of the reasons Dr. Begay mentioned. And then in terms of staffing, as we were in the planning phase, we, as I mentioned, only had 1 nurse who was comfortable managing ICU ventilated patients and the sedation that goes along with that. So we started the process of cross-training nurses from the pediatric ward, from the obstetric ward, and from the ambulatory care ward, anticipating that we're going to have to get all of the nurses in our facility comfortable managing these patients because we were anticipating having many of them in the future. Next slide, please. And this raised the question, can we really provide critical care in Chinle for COVID-19 patients? So primary presenting complaint for these patients is hypoxemic respiratory failure. We had both high flow machines and ventilators. So theoretically, we had the machines to do the job. Early on in the pandemic, for concerns of possible infection to staff, we were wary of using high flow and non-invasive positive pressure ventilation. So we were initially planning on going down the intubation route, early intubation, if patients were requiring more than just nasal cannula. And so that led us to move down in thinking about, when you intubate a patient, what do you really need? So we had anesthesiologists, we had the supplies to do the intubation, but after a patient's intubated, not only do you need a mechanical ventilator, you need sedation. You need a way to keep the patient comfortable, because having the endotracheal tube in is not the most comfortable thing. So we definitely had the medications to do that, but one place we were sorely lacking was in staff who were comfortable administering sedation sort of over the 14 days we were anticipating having to keep these patients. So that was one potential red flag we saw in a challenge we were going to have to face. Additionally, just on a pure numbers standpoint, we didn't have enough staff. At baseline, we don't have enough nurses to fully staff the hospital beds we did have, and now we are creating more hospital beds. How are we going to possibly care for these patients without having enough staff? So that was another shortcoming we potentially saw. And then finally, in thinking about managing these patients with a hypoxemic respiratory failure and ARDS, one of the critical components that's shown to have a mortality benefit is proning. As far as to my knowledge, no patient has ever been, who's been mechanically ventilated, has ever been prone at Chinle Hospital. So we had no experience with this. And we anticipated this as another potential challenge in trying to give our patients the best outcome possible. We had no experience doing the thing that the evidence suggested we should be doing. Additionally, we had concerns about PPE. Over the course of the pandemic, the only thing we've gotten very close to running out of has been gowns, but we're short on essentially all PPE for the first month of the pandemic. Now we're doing better, but that was a concern we had in providing care for these patients. Could we do it safely without infecting all of our staff? Finally, invasive monitors. We definitely had the material equipment to place the invasive monitors, but again, many of our staff did not have the comfort level of managing these invasive monitors. And finally, thinking about end-of-life decisions, very, very much in the mainstream media with these patients. Unfortunately, many of them have high mortality rates, and we needed a way to talk in a culturally competent way about sort of end-of-life decisions. And we knew we had to sort of focus on this as we planned for the pandemic, which we anticipated to arrive. Next slide, please. Oop, I think you went one. There you go, perfect. All right, so then we move on to the West, the implementing. This is the phase we're in right now, or the acting phase. So the pandemic has arrived. We've done as much planning as we can, and now we're having to act. So on the facilities side, one of the critical challenges we found is on oxygen supply. As we've moved through the pandemic, as with other academic facilities, we've become more comfortable using high flow nasal cannula for these patients. And we had initially 6 machines. And when we had just last week 6 patients on all of those machines, we drained our 1,200 gallon liquid oxygen tank by about half in just over 24 hours. Luckily, we have a fairly robust supply chain to get that refilled. But that's one challenge. And although we have the machines, do we have the back-end supply chain to continue to supply the oxygen that those machines to require to actually have a benefit for our patients? And we've so far been able to do that, but that's definitely something to consider anywhere where there's limited resources. Although you have the machines, you want to make sure the supply that makes those machines work is going to be available. Otherwise, the machines are going to be relatively useless. As we've moved along, we've gotten close to filling up our respiratory care unit with about 20 patients. And so we've started planning for overflow inpatient care into our adult side and then into our obstetrics. And finally, if we continue to have a significant surge, into our ambulatory side. Luckily, although we were anticipating initially having to keep all mechanically ventilated patients, the ICUs in Arizona and New Mexico, where we typically have transferred patients prior to the pandemic, have not filled up or had as big of a surge as we've had here on Navajo Nation. So to this day, we've been able to transfer all patients that have been mechanically ventilated, and that has been a big relief to our staff and also to our resources. Finally, in looking at sort of more machines, because we've been started using high flow nasal cannula more frequently, we've added 4 additional high flow machines. And just last night, we had 8 patients on high flow at one point. Additional things we've made that I think have been very, very effective in sort of managing these critically ill patients is moving the majority of our testing in-house. So we moved from a 10 to 15 day turnaround to having the majority of our test results within 2 hours done by our lab in-house. One of the challenges we faced in moving all of the lab testing in-house is we've been running out of viral medium, but our laboratory technicians have been amazing and have worked out a way where they can make their own viral medium, so we don't have to rely on supply chain issues to get that. So we've been able to maintain a very robust in-house testing capacity. And then finally, on the staff side, that was one of our biggest worries in sort of the planning phase, that we weren't going to have enough staff to care for these patients. And I think this is one way that UCSF has really helped us out by providing us with a significant number of nurses, especially several nurses with critical care experience. And I can speak from experience as a provider here, has been very grateful to be able to care for these patients within our facility in ways that we likely would not have been able to had we not received nurses from outside facilities. Additional folks that have helped us with nursing staff and respiratory therapy staff and also ER physician staff are disaster medical assistant teams through the United States government. And then we've also worked on setting up some ICU telemedicine support if in the future we are no longer able to transfer mechanically ventilated patients, so that we can sort of care for these patients in the best evidence-based fashion possible. All right, next slide, please. All right, and then finally, thinking about the future, we're always trying to think one step ahead of the current sort of phase we're in. So moving on to the north or the final direction and reflecting, thinking about how are we gonna eventually, after this surge is over, scale things back down, and how are we gonna ramp sort of our normal operations back up. Currently, I don't think we're even within several weeks of doing this. We've set a goal of trying to have a test positivity rate of less than 10% for 2 weeks prior to doing this. And right now we're sort of in the 15 to 18% range. Of note, we think within the Chinle service unit, there's about a 20% prevalence of COVID. So about 1 in 5 patients we think are COVID positive right now. And sort of related to this is, when are we going to be able to sort of get back to our usual staffing and not need staff assistance? I think sort of based on the testing numbers and our current inpatient census, we're likely several weeks away from that. But we're always thinking about sort of the next step of how we can scale things back and sort of get back to normal operations before we're in that phase. Next slide, please. And so that's all I have for my presentation. I know a lot of you have experienced the pandemic in many different ways, and thank you for listening to all of us. I know this has been challenging in some way for everyone all over the world, but we want to say that someday in the future, although it may not be the same beauty we had before, beauty will return, and we will be able to sort of continue on with our lives. Thank you very much.
Jaime, I think we may have lost you there. So I'll step in here. I think I want to just, on behalf of Jaime, who I think is having some internet connectivity issues, want to thank the panelists for their remarks. Also want to thank those of you who have submitted questions to the Q&A box, and would invite others to continue to submit questions there if you have them. But in the interest of time, I can summarize those questions and share them with the panelists. There was one question around trust. Obviously, COVID presents a number of challenges to health systems. If you think about not just the care and treatment, but also the challenges associated with quarantining, isolating people, finding ways to trace contacts and the like. And much of that depends on a degree of trust between the health system and the communities it serves. Given the long and painful history of that was accounted in Dr. Begay's presentation, I'm wondering if you could speak to the level of trust that exists between the communities that the health service serves and the health and the population in general. How does that play into and support the efforts to combat COVID, or how does that work against it?
I believe there is issues with trust, but I think it's more the issues with trust with the government and the system. But I think for the most part, as far as being a direct healthcare provider, and also being Navajo myself, I'm able to traverse that. And even with patients that come into the clinic, or they see a new provider, I get called a lot to kind of help with some ethical issues and some things. But I think one of the things, I mean, it may sound like so simple and so trivial. I think one of the issues that is really scaring people is the way we have to protect ourselves is PPE, and not being able to communicate really well with patients. And especially when we get to the conversations of goals of care, and that's communicated by iPad or a phone with the family, and they're not seeing a person in, and so that's been really, really difficult. It's like I said, it sounds like that would be something that wouldn't even be an issue, but I have found that it is a big issue.
Great, thank you. There was a second question, which was around testing. And I think, Sam, towards the end of your remarks, you may have answered this, but what is the status of testing there? Are there enough tests? And you mentioned before the positivity rate is around 15 to 20%. Is that because you're allocating testings in a scarce way and only treating people who are most likely to have it, or does that reflect kind of a broader understanding of the prevalence in the population?
So I can start to answer, and if anyone wants to weigh in, go for it. Every Thursday we have a situation report from our clinical director, and he actually shared something with us last week. It happened to be Lab Technician Week, but he said that if you look at per capita tests done, at least specifically in the Chinle service unit, we had done more or similar testing to the highest rates of testing anywhere in the world. So we think, at least within the Chinle service unit, that our prevalence is actually fairly accurate, somewhere in the 15 to 20% range. And I think Sri mentioned there in the chat with the comment back, our two primary tests we're using here are the Cepheid Gene Expert RT-PCR test, as well as the Abbott ID Now RT-PCR test. We also have send-out labs, but we only really use those for asymptomatic, low likelihood patients. Everyone where we have any even small suspicion, we use sort of one of the more rapid tests. And as far as I know, at least in the Chinle service unit, we do not have antibody tests, which was also part of that question.
In referencing perhaps back to Sri's opening comments about, this feels like a sprint for the UCSF folks, but for folks part of the Indian Health Service, this is a marathon, and there's a long history of health inequities. We did get a question on kind of some of the roots of the health inequities around obesity, diabetes, and what can be done about that. And so I'm wondering if all of you could speak to the question of how you deal with kind of the ongoing longer term health needs in a crisis environment, and how do you balance both resource allocation and dealing with those challenges?
Dr. Begay, do you want to start?
I was gonna say, come on, Sri, you can take this one.
No, you started and then I'll add.
So, I think one of the things is funding. I mean, that's the major issue here. You can't, you can't educate well if you don't have good educators. You can't educate well if you don't have good resources, and you can't provide resources if your main, like within Indian Health Service, we're in the facility providing care, seeing patients, and I know some of the tribally run clinics have a little bit more where they can go out into the community, and they have a little bit more resources than direct IHS sites. But and then the reservation is huge, is a huge food desert. I mean, and again, that comes down to how can we appropriately tell people this is the right way to eat, this is what you should eat, when it's going to take them 100 miles to go get things that we're telling them that they should eat. So I know we try to talk to people about exercise but there's no gyms, yes, we have the outdoor here, but we have wild dogs here and there, and so just things that, reservation life. So
I'd say, like, on the trust issue that was brought up before, practicing here, this is actually my first time practicing here. We've kind of been with Heal Fellows for a long period of time, but Heal Fellows often tell us that, the ones that aren't native, aren't Navajo, they get asked the question very early in their fellowship, like, when are you going to leave? How long are you going to stay here? And that's like one of the first questions that come from Navajo patients. And, I think like somebody like Dr. Begay shouldn't be as rare as she is, like over the the course of, I think, of a 4-year period, there was 55,000 people that graduated from medical school, and there was 101 Native Americans that graduated. I think this is like 2012 to 2016. And so, you know, I can say for being here and trying to take care of patients through PPE, the nurses that speak the language, that understand the culture, it's like night and day. Oftentimes I'll say something and, you know, there will be a blank stare, and then this Navajo nurse will come in and communicate in such a much more skillful way, obviously. And so I think that having more, you know, physician providers, nurse providers, obviously, that are Navajo or Native across the country is huge. And then there's, to add to what Dr. Begay said on diabetes and the food desert, I think there is some organizations here, program COPE, that it works here, and they're kind of an arm of Partners in Health that has worked on like food and vegetable prescription programs. And so trying to drive kind of the demand for getting, you know, essentially funding for fruit and vegetables, trying to place them in convenience stores and drawing demand through that way. You know, it's obviously not, it doesn't solve the massive problem, but it's kind of trying to drive, you know, the supply and demand in an innovative way. And they've studied that pretty extensively, of increasing, you know, for specifically, I think, prenatal care, and for like children who are young and 2 standard deviations above the BMI, you know, really driving kind of fruit and vegetables.
Thank you, Sri. Thank you, Dr. Begay. There was a, related to the resource question, people also want to know how they can help. And I'm wondering if there's any kind of advice or recommendations from you as to how people can best contribute in the spirit of solidarity to start to address these inequities. Any thoughts? Oh, and by the way, shout out to the School of Nursing, who apparently is graduating 2 folks, let me just make sure I get this right, 2 Navajo FNPs this June. So hopefully starting to address some of those inequities in the workforce. But aside from that, how else can we help?
So, like, as Sri mentioned, the COPE program actually has done some great, you know, work throughout the reservation in collaboration with the Navajo Nation's Community Health Representative Program on patient education, delivering food. But there's also a couple of other, and I can give that information, who I think there's a Hopi Navajo relief effort. There's also one that's run by Dr. Michelle Tom in Winslow, as far as donations for that area. So, and those are the big ones that I mean, and Sam, you may have different recommendations for the middle of the reservation, but those would be the ones for that I've seen seem to go directly to the residents of the reservation.
And I second that. There are 2, if you're thinking about financial funding, there are 2 GoFundMe's, one that was set up by a former Attorney General of the Navajo Nation, Ethel Branch, and now there's a more official one set up by the Navajo Nation government itself, which you could donate to.
Great, thank you. And we will collect that and try to have those links to some of those sites, in addition to the video transcript from this, which we'll post on our website at the conclusion, once we downloaded and edited the video file. So for those who have asked about those links, we'll make sure to post that, so please come back to the site and check for that. I realize we're at time, so Jaime, why don't I turn it over to you for the final, any final remarks or questions? And you're muted still, Jaime.
Before Jaime gets on, I just wanted to say one comment. Sure. That the things that I've shared with everybody is really from my own experience and from my as a Navajo woman, and does not reflect anything of the federal government. So that's just to get that out there.
Sure.
And then if I can just weigh in one, I think I cut out, but just, I think this is an institutional moment for UCSF, and we've really leaned in with equity, health equity in this moment. And I think Keele doesn't have like a huge nursing presence, which is why we leaned on the institution. And I think going forward, how do we really come with a strong leaning into equity before and after COVID, and especially after, I think it's now kind of on the radar of everyone at UCSF. And so how do we keep this momentum going from the critical care side, from the nursing side, from all types, from IGHS as well?
Thank you. Great. Well, thank you. Jaime, do you want to say any final words?
Well, just a word of thanks to all of the speakers and panelists for their wonderful contribution. I think the optimism, the resilience is something that I take home with me as a lesson. I am very impressed, Dr. Begay, with all the work you have been doing for the Navajo Nation, and I will do all my best I can to help in any way we can from UCSF. So thank you, Sam. Thank you, Sri. Thank you, Dr. Begay, for a wonderful presentation. Michael Lipnick, also, thank you for helping put this together. That was fabulous. Thank you so very much, and see you next time.